Welcome. This is Jeff with Mend, and this is the first part of a two-part climbing injury prevention and self-treatment video series from Mend. So in our first video, we'll discuss common climbing injuries, how we can prevent those injuries, and then some proper self-assessment you could do as a climber to help reduce your risk of injury. So we're a sports medicine practice here in Boulder, Colorado, where we focus on the treatment of athletes in many different sports, including climbing, and really pride ourselves on problem solving and getting down to the root of the issue quickly and getting people better in 2 to 4 visits, not requiring that traditional physical therapy approach of 16 or 20 visits, but really getting to the heart of the problem. What are the contributing impairments, and how do we get this athlete back as soon as possible to their respective sport? More information can be found in our practice on mendcolorado.com. So this is kind of a funny ad, but clearly things have changed in the climbing community where we're seeing a increased attention towards health and fitness and staying overall well-being while climbing. Although hygiene may not have changed too much with the dirtbag climber, but we do know that they're getting stronger, more fitness, and trying to stay well while they're on the wall. So as we discussed, we'll be discussing in this two-part series, this first section, common climbing injuries, what we can do to help prevent those injuries, and how you know if you're in a proper category to work on core strengthening or shoulder strengthening based on some self-assessment tests that are out there. In our second video, we'll talk about how do you treat these common impairments that we see in climbers, like a loss of thoracic mobility, scapular weakness, rotator cuff weakness, and so on. So we do know that climbing has become a very popular sport, especially here in Boulder, Colorado, definitely one of the top outdoor sports. There are about 10 million Americans participate in climbing both indoors and outdoors in a given year. What we find is that each climber is going to describe about 1 or 2 unique injuries in their career. The vast majority of these climbers, as we're going to find, are going to come back to their sport before feeling 100%. We know that more than 90% of these injuries are overuse in nature. So thinking about your tendon injuries and your soft tissue injuries, those are the injuries we're going to see the most in climbing, with about 10% are going to be more in that traumatic category. Some of the risk factors, as you could imagine, for climbing would include climbers that are higher level, thinking about more of a lead climber, and also those that have more climbing volume per week or more climbing volume per year. They just have more chances to sustain an injury versus the climber with a lower climbing volume. As we mentioned, number one risk factor would be a prior injury. So most climbers, again, return to their sport before being completely healed, and that may precipitate either an injury in the same area or an adjacent area in the body. So what we find is that those climbers are going to be 6 times as likely to have a second injury after they've had their first injury. And over half of these climbers are going to return to their sport before they're ready, and also half of them are going to have symptoms while they're returning to their climbing sport. So that may indicate that that tissue still has a limited tolerance for activity. It still requires rehabilitative exercises to get that tissue back to feeling 100%. Some of the things we can do to reduce the risk is, of course, climbing within your limits. Not just on the difficulty on the wall, but also knowing your climbing volume. How does your volume look like the last 4 or 5 weeks? And then how does your volume this week compare to that moving average over the last month? So having a sudden increase in climbing volume in days per week, or intensity of the climb, or duration of the climb, all those could be risk factors for developing that overuse injury along that common path of injury with doing too much too soon. Also thinking about reducing your risk with exercises. We know that strength training is a very effective way to reduce injuries on the whole, with most research showing a reduction by half or 2/3 in a strong climber compared to their sedentary peer that just focus on just climbing. And then finally think about making that gradual progression over time that reduces that risk of overuse injuries in the tissues and allows that tissue to adapt and become stronger and be able to tolerate those higher levels of climbing. So in this lecture, we'll talk about some common climbing injuries, including those to the fingers, thinking about those flexor puller injuries. Also thinking about lateral elbow pain. Some people call this tennis elbow. That's kind of an umbrella term. We'll talk about why that's more known as a tendinopathy. Also low back pain. And of course into the shoulder, thinking about rotator cuff tendinopathy, impingements, and also we can find some instability or laxity in that shoulder joint. So many of you probably know someone or may have experienced yourself a pulley injury in the hand. We know that these pulleys act like eyelets on a fishing rod. They improve the tensile strength of the pulley and the flexor tendons of the fingers. And we see this as a very rare injury outside of climbing. It's really an injury that's very unique to climbing because the unique pressure is placed across the pulley in different grips into the. So oftentimes climbers will describe a pop with acute pain and swelling, usually on the palmar side of their hand. Most commonly, it's going to be the A2 pulley that's going to get injured. And if you look at this picture on top, we can see that the pulleys are numbered from proximal to distal. And underneath where your fist would be, that fist knuckle, called the MCP joint, that's where the A2 pulley is commonly torn. And what we tend to find is if you have multiple pulley injuries, you can get some bowstringing effect where the flexor tendon can be away from the bone on the finger, and you can actually move that tendon forward and back like a bowstring. And so that would indicate, again, that it was more than one pulley that was torn. Some of the main factors for these pulley injuries would be too much too soon, that the external load placed on the hand through a ballistic movement or an increase in climbing intensity was greater than the tissue's tolerance. And so therefore we have that acute injury to the pulley. Also, the amount of flexion across the PIP joint. So the PIP joint would be the first joint past your fist knuckle, and that joint in the top picture, you can see the flexion there. That's kind of a unique crimp position that we see in climbing, and probably one of the reasons why we see that this pulley injury is unique to rock climbers. Secondly, we can grade these severities from 1 to 4, where 1 is the least severe, up to 4 being multiple ruptures across that pulley system. So a common question would be, do I need imaging? Obviously an x-ray is not going to show this because it's a soft tissue injury. So do I need to require an MRI or maybe a CT scan, right? And what we find is that the recommendations out there is that imaging is only really needed if we suspect a high-grade injury. So if you had bowstringing of the flexor tendon, that would indicate, again, multiple pulleys that were injured. But if we look at all pulley injuries, that would only account for about 6% of those pulley injuries. So the vast majority, 94%, are not going to require an MRI. These majority of these non-severe pulley injuries can be managed conservatively with physical therapy and time off without that need for imaging. So one of the things we want to look at for these videos is that they're all on our YouTube page. If you go to youtube.com and search for Men Colorado, all the videos that you'll see throughout these two presentations will be there. In our clinic, we tend to test for finger strength, giving kind of a standardized position that will play on this video. So we use a dynamometer that helps us gauge the amount of finger strength that a climber has. So we can see if there's any side-to-side difference in different pull positions that may have precipitated that injury. And also for an injured climber, when do we know they're ready to get back on the wall? When can they get back into climbing? Oftentimes when this strength has returned. So using rehabilitative exercises to get that patient stronger, which we'll show in the coming videos. But once they're there, kind of testing for that grip strength. So the dynamometer is a great tool to check for that specific strength that we would utilize during climbing holds with the climbing block that we showed. So what do we do for treatment? One of the things that's been out there a lot that we have a video on is taping, and often offering some external support from just some athletic tape is a great way to help reinforce that pulley system. Essentially, those eyelets that we would have on a fishing rod, trying to create more eyelets and more support across that pulley system to reduce that risk of that A2 pulley injury. Some other things we can do for prevention is really knowing your skill and knowing your tissue limits. Again, asking yourself, what did my climbing look like over the last month? And does this week's climbing, is it a small increase from that 1 month average, or is it a large increase over the 1 month average? And the closer you are to that large increase, the higher your risk is going to be for that overuse injury. The other thing we notice is that the dynamic movements where you kind of are jumping hold, those are of course going to put more force through that pulley, especially if we get into a crimp hold. So conditioning is a great way, including hangboarding. We utilize hangboarding to help strengthen in different grip positions. Be careful on the climb boarding. It can be a very intense way. It can also be a way you could injure yourself if you weren't prepared for that. So working with your climbing professional to kind of know when that's appropriate to start working on the climbing board. And usually most professionals I've talked to have said not until about a year of climbing experience to start working more specifically on those holds. In general, looking at grip strengthening that we'll show in the next video can be an excellent way to help condition your hands, to help strengthen that tissue tolerance, just give you more resiliency, and make it less likely that you're going to have that overuse injury to the hand. If you were to sustain a pulley injury, oftentimes we're going to mobilize the joint, and usually using taping can be recommended from 6 months up to 12 months, again, to try to reinforce that pulley system and reduce that risk of a re-injury. Okay. Thinking about a progressive loading program where we start with a little bit of loading, let the tissue catch up and become stronger, and then progress into higher levels of loading as the tissue becomes stronger, with a total recovery time, depending on the severity of the injury, in the literature will report between 6 and 24 weeks. So this is just one of the videos that's on our YouTube page. We also have a video of the taping if you're interested in that. So the hand's a very dynamic structure. You can use a lot of different tools to strengthen the hand. We can use a crush grip and also a crush grip to the 4th and 5th finger, a pincer grip between the thumb and the index finger, and working individual digits. So there's plenty of tools out there on the internet and on Amazon that you can look for, and essentially you just need some type of resistance. I would also work into extension, trying to open up your fingers against a rubber band. Rubber bands look great for that, just like you can use a ball to squeeze. And trying to train more of a spherical grip, thinking about all the grips you might utilize during your climbing on different walls and different intensities, and try to recreate those grips as we work local to the fingers and hand. And then finally this chuck grip. So the hand's very dynamic, very strong structure. We want to try to create the strength program for all those individual muscles, probably not using very much weight for those exercises to start, and then building up that strength over time. So one of the things that's really changed in my career since I started in the early 2000s was we've stopped calling these tendon injuries tendinitises. Back then we used to treat these with things that would help reduce inflammation like anti-inflammatories and immobilization and ultrasound. And what we've really found from the research now is that when we do biopsies of injured tendons, we don't find any inflammatory cells. And what we find instead is a cell turnover that's taking place where new collagen is being laid down, new tendon cells are being laid down. But when they get laid down, they're immature and they have weakened tensile strength. So they're not quite sure what to do when they get laid down, and that's what we call a tendinopathy. The best way to help those cells mature and become strong, where they're back into a healthy alignment, like the picture on the left, where they're all in tight bounds of parallel strands, we're going to try to use exercise to help load that injured tissue to move it from the picture on the far right to the picture just left of that picture. So most commonly in a climber, we're going to see these across the rotator cuff. That's going to be the number one reason why you have shoulder pain, including the supraspinatus tendon in the rotator cuff. Sometimes in a climber, what you'll notice is if the rotator cuff is overpowered or it's weak to begin with, you'll develop more what we call proximal biceps tendinopathy. That would be more pain on the front of the shoulder versus more on the outside of the shoulder. What we're going to find for the main causes of these injuries would be a training error, where you did too much too soon and your climbing volume exceeded the tissue's capacity to heal. And when you exceed that tissue capacity, you're going to develop acute pain, which could translate into kind of a dull, achy pain. Tendons that are in the later stages of recovery will oftentimes be painful when you start the activity. As you continue to climb, the pain will subside or go away, and it sometimes can return that evening or into the next day. So we want to be careful of that latent pain and keep an eye on that soreness as we start to return to climbing. The other thing we can see is that when our mechanics are poor, when we put additional forces through a healthy tissue like a biceps tendon that wasn't designed to do the work, over time that can create that same tendinopathy pattern. So again, keeping the rotator cuff strong to help prevent additional loading on the biceps tendon. So in our clinic, we find that the research supports a hands-on approach, and when we follow the research for tendon injuries in the shoulder, treatment of the thoracic spine with manipulation, treatment of the shoulder with mobilizations, and also with muscle activation techniques is a great way to help transition an injured patient into a high-level strength training program, which we know is the best thing for the long-term relief. So the hands-on techniques are more appropriate in the short term as we look to reduce pain and improve mobility. And as we look to return this injured climber back to full climbing capacity, that's really where the most important thing is a strength training program. So when you think about your tendons, always think about a progressive program. That most of our patients that come in have been to the internet and they've searched and they've found different exercises. And the main reason why they're not feeling better is they weren't doing enough activity, or they initially found gains with the exercise and stayed there. They didn't progress, and that's why the tendon is in a certain state of injury. So in order to get better, you have to think about a stair-step example where you keep progressing along the lines of the stairs and let the tissue catch up before progressing to the next level. So just like in this picture, how do we progress that athlete from beginning to end with gradual progression of strengthening, kind of that positive stress, that eustress, that's going to help take a tendon from a tendinopathy back into a healthy tensile state. If we watch a tendon over time on ultrasound, it can take sometimes 10 or 12 months, sometimes up to 2 years, to get back to 100%, what we consider kind of a healthy tendon. Although you won't be feeling pain at that point, it's important to continue to strengthen from about 8 to 12 weeks. That's usually when the pain is going to disappear with a tendon injury with exercise, and continue to strengthen up to a full year to help reduce your risk of recurrence from this tendon injury. So here would be a video here from our YouTube page with some progressive loading. So what we're going to see is we're going to start with an isometric. Those are great ways to strengthen, to start with just using the involved side, and then taking the uninvolved arm and applying kind of an equal and opposite resistance. And that could be held for 30 to 45 seconds with a light load that's been shown to provide some pain relief. Is also start with the initial basic loading of the tendon. So with a really irritated tendon, this is a great place to start, just some gentle isometrics. This would be used for the supraspinatus. Again, we mentioned that's the most commonly injured tendon in the shoulder. But if you're going to use for infraspinatus or subscapularis, you would go a different direction. Once that's starting to feel better, we want to start to progress into more active movements. So this would be called a full can exercise or a scaption exercise. So it's about 45 degrees off the frontal plane. This would be a great way to strengthen the supraspinatus through more of a dynamic movement. You could use a can of soup, a light dumbbell, some TheraBand, whatever you had to provide some resistance. That'd be a great way to help strengthen that tendon through that range of motion. As you get stronger up towards horizontal, then you can move to more of a vertical movement. So going above horizontal into more of a press. So this could be utilized with more of an overhead press. You could use a dumbbell, you could use a kettlebell. Usually what we'll do is we'll keep your strength up below horizontal first. Once you get the strength back from right to left, then you can start to move above horizontal into more of a vertical movement. So how about lateral elbow pain? That's what we used to call tennis elbow. That's kind of an umbrella term that doesn't really describe the injury very well. We used to call this a tendonitis, where all the muscles that attach from our fingers, that would extend our fingers or extend our wrists, that would be very involved in that climbing pattern, that would come into the outside of the elbow here. Those all attach into the same point on the outside of the elbow bone. So that's usually where that's going to be most tender and most painful for a climber. Again, we're getting away from calling these tendinitises and calling it more of a tendinopathy of those common extensor tendons. So those would be, again, the muscles that would extend your wrist, extend your fingers, like going for a long hold, as well as muscles that would turn your palm to face your face, kind of facing upward there. So these injured athletes will often describe pain with gripping, lifting, and carrying, all kind of common things we might utilize on the rock wall as we begin to hold through our fingers and hands. Again, thinking about the risk factors would be, again, that the forces that you utilize during climbing would be greater than the tendon's capacity. You guys know that as you go towards a smaller hold on the rock wall, either indoors or outdoors, the more of a pincer grip you're going to need, the more work you're going to have through your fingers and also into your elbow versus those nice broad hand holds. So if you've gone from using broad hand holds to smaller hand holds, that could be another risk factor of too much too soon, and just making more of a gradual return to smaller hand holds. Looking at the research for lateral elbow pain, there's been research for manipulation by physical therapists, both for the neck or the cervical spine in that picture on the left, as well as the thoracic spine like we showed in the shoulder slide. And also a lot of research has gone into what they call mobilization with movement. So in this picture on the left, trying to mobilize the elbow joint during a gripping activity. So it could be gripping a ball, it could be gripping a towel as the treatment is applied, has been shown to reduce pain in the outside of the elbow and also improve grip strength. So the ability for you to grip harder before producing the pain response. So it's a great way to transition into a loading program If pain is the limiting factor, the mobilization with movement can reduce that pain and allow you to transition into the loading program faster. So thinking about progressive loading, the video that we showed for the grip strengthening, we can use finger extension and thumb extension to help target those common muscles that insert into the outside of the elbow. And as those get stronger, then we want to progress into more higher level activities. So thinking about a pull-up, maybe a pull-up with assistance, some type of pulling movement or gripping movement so we can replicate the demands on the shoulder and elbow that we would see with climbing, but in a more controlled environment. And then eventually, of course, returning to the climbing of larger holds into smaller pincer holds. So here's just a video on some elbow strengthening. So we can start with some elbow extension. And as we lift the dumbbell up, we can work on isometrics to start. As we work into extension, again, a 45-second hold, then transitioning to more of a dynamic movement, more of an on and off movement, focusing on the lift, but also on that slow lowering, which we know is where most of the strength is developed. And we think that a lot of tendons can benefit from both working upward on the positive movement and also on the negative or the lengthening movement of the wrist. We can also work a little bit heavier by having a little assist from the uninvolved side and then lowering with the involved side. So we're about 30% stronger on the way down than we are on the way up, but it's oftentimes difficult to lift that much weight on the way up, but we can give the left side to give an assist, and then we can really work eccentrically, again, 30% heavier on the way down than we are on the way back up. And then transitioning into something more dynamic with shoulder extension. So we can still work those same finger and wrist extensors with more of a bigger shoulder movement. So again, start local and then start to move more global into more of the shoulder and other arm exercises there. So some of the tips we can give you for a tendon, it kind of reminds me of someone, maybe you might have a friend that's always short on money, they're always missing their rent, they're always having difficulty time paying their bills. Well, the main thing we can tell that person is you need to make more money or spend less money. That's what we can do with a tendon as well. We can either improve its capacity, and the best way to improve a tendon's capacity is to work on strength training. The other thing we can try to do is reduce the climbing volume, so essentially you're spending less money. So in the short term, we don't want to shut you down as a climber. We're oftentimes going to try to find what's the level we can give you that's going to meet the tissue tolerance of climbing. And then as we try to improve that tissue tolerance, the best way to do that, the best way to get money more into your account is through strength training. So we want to try to get that recovery of balance between how much loading you're doing and how much recovery we're giving the tendon. So in short, doing too much is just as bad as doing too little. We need to find the sweet spot for how much loading we can give to this tendon to promote healing and adaptation, but not overwhelm the tendon, not overcook the tendon. Commonly what we'll find in these tendons is that they can have some mild pain during the activity, and that's pretty normal for a tendon. So we would look for a pain of about 1, 2, 3, or 4 on a scale of 0 to 10, where 10 is the worst pain imaginable. And then we should find that this tendon comes back down to baseline. It comes back down to how it felt before you started climbing within about an hour or two after you finish. Like I said, that'd be pretty normal response for a tendon. If the pain's getting into a moderate category above a 3 or a 4, or if it lingers for more than 2 hours after you finish, and again, in those later stages of tendon healing, you'll have some latent pain where it feels better when you climb. It just hurts that evening or that night or into the next day. If that's the case, again, we want to back down our level of training volume. So be really patient with this. Recovery is not going to be a straight line between time and the amount of recovery, like a 45-degree angle. It's going to be some ups and downs, and that's pretty normal for a tendon. Try to be consistent, try to be patient, and really try to keep a training log. If you can keep a little log on your phone of how much climbing you did, how intense the route was, how long the route was, how much total duration did you do, that's going to let you know how you did in the last month, and if this week is pretty consistent with last month, or is it too big of a jump from this week from the last 4. So low back pain is a common complaint really for everybody. We're getting to that point where it's, the 3 certainties in life are becoming death, taxes, and low back pain, with over 90% of American adults reporting low back pain at some point in their lifetime. Thankfully, the vast majority of back pain is benign in nature. It doesn't indicate any severe injury or illness that would require an MRI. And a lot of these symptoms are going to improve over time. One of the things that we do find is that physical therapy helps accelerate that recovery. So if we get physical therapy early, we can expect an accelerated recovery versus a prolonged recovery for low back pain. So we know that the spine has a lot of innervation. It has a lot of nerve supply. It kind of reminds me of a fingertip. And when we have a small injury in the back or a moderate injury in the back, it hurts a lot more than somewhere else in the body. Just like if you were to get a paper cut on your finger, it hurts like crazy, although there's not much tissue damage there. So again, it's just from the convergence of neural input and nerve supply to the spine that makes a strain or a sprain feel much more painful in your spine than somewhere else. Some of the key advice would be to stay active within your pain limits and start to address what mobility needs that you have, what you need to work on for mobility, and also what do you think about from a strength training standpoint. So as the pain begins to resolve, to help reduce that risk of it coming back, strength training is the #1 goal for that. So if we look at MRIs, we tend to find that they've become very, very sensitive. They're not going to miss anything on your spine. They're going to find every wrinkle, every change in your spine. But what they have is they have a lot of false positives that we see a lot of pathology in people who have no pain. This was in an excellent study in 2014 of over 3,000 people who didn't have any back pain. And they imaged all these people in different age categories that you can see across the x-axis of the graph. And when they imaged these people, they found an increasing degree of pathology from disc injuries to facet or the joint injuries to even spondylolisthesis, especially increasing as we age. So if you take yourself, if you're a 40-year-old male, you can see that 70% of those 40-year-old males in your peer group had disc degeneration, and about 50% of those males had disc bulges, right? And so on through the graph. So again, as we age, we accumulate different changes, just like we have wrinkles on our skin or we have gray hair, and these things can happen in our spine too. So just be wary of your MRI scan. Um, if you do have a positive image, make sure that it correlates with your symptoms, that you're working with a medical provider to put those imaging findings in perspective. So when we get into the mobility category for back pain, manipulation has been shown to be very effective by physical therapists using that spinal manipulation, especially acutely in the early phases of the recovery. And then moving into more of a mobility treatment, so you can kind of work on your own back pain by working on some exercises to help reinforce that manipulation. And then working into stability programs, working into posterior chain exercises like deadlifts, working on some anterior or front of the body chain exercises like the abdominals or the pecs, thinking about how we can incorporate more of that stability work to help reduce that risk of the back pain coming back. These are some of the things we'll talk about in the second lecture. And a couple of things we're going to put in for your own kind of self-assessment is take a look and see if we can help reduce that risk of injury. We can't prevent an injury, but what we can do is help reduce your risk of injury with a couple simple tests. So the first test you can try on your own is called the Closed Kinetic Chain Upper Extremity Stability Test. And what you want to try to do is make two pieces of tape or two marks on the floor about 36 inches apart. Although the test is pretty strict about 36 inches, obviously we can reduce that width for a smaller climber. So for a smaller female, for example, there's no reason why we couldn't bring that tape in, although we might change the validity of the test. So what we're going to try to do is make repetitive tapping, so tapping from right to left that we'll show in the next video. And you're going to count how many taps you can do in 15 seconds. And we'll do a total of 3 trials with 45 seconds in between to rest. And what the research has shown that if you can make less than 21 taps, that you are 19 times more likely to have a future injury. So again, a predictive test that may indicate some core weakness, some shoulder blade weakness, or some arm weakness. So we'll take a look at the test here. So again, we keep our tape marks about 36 inches apart. This could be modified, and I do modify it for my patients as needed. But Kristen here is doing the full 36, and she's keeping an eye on how many taps she can do in a given 15-second time period. And then pretty fatiguing at the end, obviously. So kind of going to that point of fatigue, you can keep an eye on how many taps you did, and that may place you into the normative values here. So we can see that for an active female like Kristen, we can look at, she should get to about 27 to 32 taps in a given 15-second time period. For an active male, we can look for about 24 to 27 taps from side to side. And then we can see what could happen in the injured category as well as with a sedentary individual. So this might indicate if you're getting back into climbing after an injury, are you back to 100%? We know that most climbers, about half of them, are in return to their sport when they're still symptomatic. So it's possible that they're still at risk for injury, especially a future injury to the same area of the body. How about mobility? You can do an easy self-test for how much back mobility you have, and we'll talk about this in the second lecture on what you can do to try and improve your extension if it is limited. If you imagine the bottom of the shoulder blades, so that would kind of be right here on VP. If we were to drop a plumb line down, the shoulder blade should be just behind the heels of the feet. If you cannot bring your shoulder blade behind the heels of your feet with your arms overhead, that would indicate that you have limited extension, and you could work on some of that extension to help with reducing that risk of back pain or trying to get back to 100% after having an episode of back pain. Also, overhead mobility could be an issue. So this would be a video here looking at overhead mobility. So essentially you're going to reach overhead with both arms. It's kind of a pre-test to kind of see how far you can go. What's that distance between your hands and the floor? You can choose some exercises to help work on that. And this is some of the things we'll cover in that second lecture. So there's some things we can do to help improve that overhead mobility, especially if you're limited either at the ball and socket joint of the shoulder or more of the thoracic spine and rib cage area. How about the core? The core is a very much an umbrella term. What does that even mean? It's hard for us to describe. Although when we utilize core in normal conversation, both patients and clinicians can understand what we're talking about. What the Bunky test is going to help you do is decide which part of your core you need to work on. Is it the front of the body? Is it the side of the body? Is it the more of the back? Where the back and hips are the glute muscles, so the posterior chain. So the Bunky test is a great self-assessment to determine where is your weak link. If you look at the pictures here, is it more of the side of the body that's the weak link? The middle picture shows the back of the body, and the bottom picture shows the front of the body. So the Bunky test is an excellent self-test that we'll show in the video. You'll use about a 10-inch step. That might be like the stairs. Could be a few textbooks you have floating around. That's what you're going to hold your feet from. And you're going to do a sustained hold. So how long you can hold that position without breaking your form or causing pain. If you were to compensate or if you had any pain, that's the end of the test. And if you can't get to 40 seconds, that may indicate that's a line of muscles you need to work on for homework. So not just working on the muscles you're good at, but try to work on the muscles that you're weak in and try to identify that weak hold. So here's the Bunky test here. So again, this is on our YouTube video. So Kristen's working on the lateral line first. Again, she needs to be able to hold for a 40-second hold without having any compensation where your hips drop towards the floor, you rotate. So there's the front of the body, the anterior chain, that may work, and then the posterior chain. So looking at both right to left differences, as well as differences around the size of the body. And then finally, the most brutal one is usually this inner leg one for more of the medial line. We find that a lot with females, that's a weak link for them, thinking about the inner thigh adductor muscles and the deep core muscles of the body too. So give that a shot at home with the Bunky test. It can be very kind of eye-opening. So that kind of concludes the first part of our lecture on climbing injuries. We discussed the common climbing injuries, as well as a couple ways we could help reduce that risk of climbing injuries, thinking about the closed chain upper extremity stability test, as well as the Bunky test to help identify your weak links and things you need to work on. If you weren't able to reach the normative value for TAPS on that upper extremity test, that may indicate you need to work a little bit more on your core stability, shoulder blade strength, as well as rotator cuff strength that we'll kind of cover in this next lecture. So thanks for listening, and we'll follow back up in the second lecture next. Thank you.